Hello everyone, welcome to Mediccom Event 4. My name is Aryan Chowdhury, founder of Mediccom.
And I am Namita Pasanuru, also founder of Mediccom.
And today we're going through Event 4 Mental Health. This is the first time we're live streaming ever, so hopefully a lot of you are watching our stream, and I'll go through what our event will come by today. So first of all, we'll have our introductions until 11 o'clock, where we'll go through the whole event and talk about what kind of things are going to come up and the links. Next, 11 o'clock, we'll have Group 1 Dementia, who are Tanya and Menaz, who are going to give their PBL presentation. And following, we'll have Dr. Kavita giving her feedback for each group. She'll also introduce herself at the start. And then at 11:30, we'll have Group 2, Schizophrenia. And 12 o'clock, we'll have lunch for an hour. And then at 1 o'clock, we'll have Group 3, Anorexia and Bulimia. 1:30, we'll have Group 4, Autism. And 2 o'clock, we'll have Group 5, Bipolar disease. Then at 2:30, we'll have founders of Health for Curriculum. And finally, we'll have Dr. Al Pocha, our guest speaker, who will be giving us some advice on personal statements. Then we'll introduce our next session and give our goodbyes at 3:10. So now on to our first links. So I'm going to share my screen briefly and just show you what kind of things we have in store today. Okay, so this is Health for Curriculum's Just Giving page, where we'd like to donate to help them push their agenda forward, which is trying to get mental health on the Welsh Health Board to teach students more about mental health and mental health diseases. So this is why Mediccom has been founded. We want to help give do our part for our community with each event, helping as many people as we can with these charities, as we're learning about these syndromes that are coming, and there are actual people who suffer from them. So we want to give our part as medical students. Next, I'd like to highlight attention to our reviews page, because it would be very helpful if people could write reviews for us. Here it says reviews, and it would give us publicity and also help you with your future reviewing skills and use of Google. So this helps our business nonprofit spread around the UK, and more people seeing it, and hence more people joining. So that would be very helpful for all of us. Finally, I'd like to introduce Dr. Kavita to introduce herself, and as she will be our judge today.
Thank you, Aryan. Good morning, everyone. I'm really excited to be part of this group today. Like Aryan said, I'm Kavita Pasanuru. I'm a consultant child and adolescent psychiatrist. I work in Enerin Bevan University Health Board, based in Gwent. A little bit about myself. I've graduated from India, came here to pursue my higher training in psychiatry. I've done core psychiatry, which means general adult mental health, old age mental health, learning difficulties, addictions, forensic psychiatry, and then specialized to do child and adolescent mental health. So at the moment, I deal with mental health difficulties in children and young people up to their 18th birthday. So lots of things that I'm excited to hear from the group today, from the presenters, and to share some of my knowledge and experience of working in mental health. So that's about me. And like I said, I'm really excited to be part of this group today. Over to Aryan or Namita.
Yes. So now I think we should be ready for group one, if everyone is here, to present on dementia. Yeah. So take it away if you're all ready.
Okay, hello everyone. I hope you all are doing well. Unfortunately, not all of the members of our group could be present today. However, they did contribute heavily towards the research. Me, Mehnaz, and Tanya will be talking to you today about dementia. So, dementia is not a disease in itself. It's a collection of symptoms that result from damage to the brain caused by different diseases, such as Alzheimer's. These symptoms differ according to the part of the brain that is damaged. Different types of dementia can affect people differently, and so which the symptoms are also dependent on that person. Not everyone with dementia will experience the symptoms in the same way. However, there are some common early symptoms that may appear sometime before a diagnosis of dementia. These include memory loss, difficulty concentrating, finding it tough to do familiar daily tasks, such as getting confused over the correct change when shopping, having trouble keeping up with a conversation or finding the correct word, and being confused about where you are or how long you've been there, and mood changes. So these symptoms are often mild and may get worse only very gradually. It's often termed mild cognitive impairment, as the symptoms are not severe enough to be diagnosed as dementia. A GP will inquire about symptoms and other elements of patients' health. They'll also ask if they're finding it difficult to manage everyday activities such as washing and dressing, which comes under personal care, cooking and shopping, and paying bills, things that one would normally do without any sort of problem in their daily life. It is important to note that at this point in the consultation, someone who knows a patient well should be with them so that they can describe any changes or problems they've noticed and the patient maybe has not. So the first thing that a GP may do is a referral to a dementia specialist. The dementia can be difficult to diagnose, especially if your symptoms are mild. If the GP has been able to rule out other causes for your symptoms, they'll refer you to a healthcare professional who specializes in diagnosing dementia, such as a psychiatrist with experience in treating dementia, a doctor specializing in LDB care, also known as a geriatrician, a doctor specializing in the brain and nervous system, a neurologist, or a specialist may even work in a memory clinic with other professionals who are experts in diagnosing, caring for, and advising people with dementia. The specialist may organize more tests. One of these might be a brain scan, such as a CT scan or an MRI scan. They may also do further, more detailed memory tests. If the specialist is still not certain about the diagnosis, there may be need to have further, more complex tests, but most cases of dementia can be diagnosed after these assessments. There is no single test for dementia. A diagnosis is based on a combination of assessments and tests, so these may be done by a GP or a specialist at a memory clinic or hospital. The next step would be taking a history. So this is usually done by a GP. If the patient is referred to a specialist, though, a more detailed history will be taken. So the doctor will first ask how and when symptoms started and whether they're affecting the patient's daily life. They'll check whether any existing conditions, such as heart disease, diabetes, depression, or strokes, are being properly managed. They'll review any medicines you're taking, including prescribed medicines, those bought over the counter from pharmacies, and any alternative products, such as vitamin supplements. They'll next do mental ability tests. So people with symptoms of dementia are given tests to check their mental abilities, such as memory or thinking. These tests are known as cognitive assessments and may be done initially by a GP. There are several different tests. A common one used by GPs is the General Practitioner Assessment of Cognition. Although these tests cannot diagnose dementia, they may show there are memory difficulties that need further investigation. Most tests involve a series of pen and paper tests and questions, each of which carries a score. These tests assess a number of different mental abilities, including short and long-term memory, concentration and attention span, language and communication skills, as well as awareness of time and place, which comes under orientation. It's important to remember that these test scores may be influenced by a person's level of education. For example, someone who cannot read or write very well may have a lower score, but they may not have dementia. Similarly, someone with a higher level of education may achieve a higher score, but still have dementia. And lastly would be the dementia brain scans. Brain scans are often used for diagnosing dementia once the simpler tests have ruled out other problems. Like memory tests, on their own, brain scans cannot diagnose dementia, but are used as part of the wider assessment. Not everyone will need a brain scan, particularly if the tests and assessments show that dementia is a likely diagnosis. These scans may also be used to check for evidence of other possible problems that could explain a person's symptoms, such as a stroke or a brain tumor. An MRI scan is recommended to help confirm a diagnosis of dementia and the type of disease causing dementia. It provides detailed information about the blood vessel damage that happens in vascular dementia. It shows shrinkage in specific areas of the brain. For example, the frontal and temporal lobes are mainly affected by shrinkage in front temporal dementia, while usually just the temporal lobes are affected in the early stages of Alzheimer's disease. A CT scan can also be used to check the signs of stroke or a brain tumor, but it cannot provide detailed information about the structure of the brain. Even if a brain scan does not show any obvious changes, this does not mean someone does not have dementia. Etiological factors. So, some disorders that cause dementia can run in families. Doctors often suspect an inherited cause if someone younger than 50 has symptoms of dementia. Dementias are often grouped by what they have in common, such as the protein or proteins deposited in the brain or the part of the brain that's affected. Some diseases look like dementias, such as those caused by a reaction to medications or vitamin deficiencies, and they might improve with treatment. Progressive dementias. So these are types of dementias that progress and aren't reversible. These would include vascular dementia. This may occur in people who have long-term high blood pressure, severe hardening of the arteries, or several small strokes. Strokes are the second most common cause of dementia. A single stroke is when the blood supply to a part of the brain is suddenly cut off. Lots of mini strokes that would cause tiny but widespread damage to the brain. However, not everyone who has a stroke will go on to develop vascular dementia. Problem-solving difficulties, slowed thinking, and a loss of focus and organization are the most prevalent symptoms of vascular dementia. These are usually more noticeable than memory loss. Next would be Alzheimer's disease. This is the most common cause of dementia. Between 60 to 80% of people with dementia have Alzheimer's. Although not all causes of Alzheimer's disease are known, experts do know that a small percentage are related to mutations of 3 genes, which can be passed down from parent to child. Alzheimer's disease is thought to be caused by the abnormal buildup of 2 proteins called amyloid and tau. Deposits of amyloid called plaques build up around brain cells. Deposits of tau form tangles within the brain cells. Next would be dementia with Lewy bodies. This can cause short-term memory loss. Lewy bodies are tiny clumps of a protein called alpha-synuclein that can develop inside brain cells. Dementia with Lewy bodies is closely related to Parkinson's disease and often has some of the same symptoms. Common signs and symptoms include acting out one's dreams in their sleep, seeing things that aren't there, visual hallucinations, and problems with focus and attention. Now moving on to the last common causes. Infections such as late-stage syphilis. Antibiotics work well to treat syphilis at any stage, but they can't reverse the brain damage already done. Another one, Creutzfeldt-Jakob disease. This is a rare and fatal condition that destroys the brain's tissues. Multiple system atrophy. This is a group of degenerate brain diseases that affect speech, movement, and autonomic function. And lastly, Parkinson's disease. Dementia is common in people with this condition. Some reversible causes of dementia would be low blood sugar, brain tumors, infections, and immune disorders. Dementia-like symptoms can result from fever or other side effects of your body's attempt to fight off an infection. Multiple sclerosis and other conditions caused by the body's immune system attacking nerve cells also can cause dementia. And also, lastly, medication side effects. Side effects of medication, a reaction to a medication, or an interaction of several medications can cause dementia-like symptoms.
One moment. Okay. As with most medical complications, diagnosis of dementia begins at a GP consultation. At this stage, warning signs include struggling to manage daily mundane activities and/or memory issues. However, fragmented memory isn't a symptom only linked to dementia, and could be a side effect of medication, an underactive thyroid, a condition such as depression or anxiety, or even simply a result of old age. While there are many tests and measures that can be taken to differentiate dementia from others, some of the most common are listed here. CT scans can help identify physical possible signs of dementia, such as loss of brain mass or changes to blood vessels, while MRIs can help show proof of minor strokes or tumors, also linked to signs of dementia. Simple physical examinations can determine whether head injuries are a possible contender, and more complex neurological exams often occur to gain a deeper understanding of the patient's symptoms. This could reveal a psychiatric issue, such as depression to be the cause, as apathy, confusion, and emotional withdrawal are symptoms often confused with dementia. Even extreme dehydration can lead to confusion. A CDC blood test could also be carried out to measure the concentration and characteristics of the components in the blood, and this can indicate complications such as anemia, which has a common symptom of fatigue and cognitive difficulty. Similarly, changes in blood sodium, calcium, or other compounds can cause reversible symptoms similar to dementia. Patient history could reveal that they have consumed medication that has ingredients known to have a possible side effect of memory loss. These types of medication usually have a sedative, calming effect as they work by blocking the action of important chemical messengers in the brain. Moving on to the diagnostic criteria, the ICD is defined by the World Health Organization as the global standard of health data and clinical documentation, and it provides a set of criteria needed to be met before diagnosing someone with a mental disorder. There must be a decline in memory proven by neurophysiological or cognitive assessments. Its severity falls into one of the following categories. I've had a little malfunction. Mild. Daily activities are impacted by memory loss, but independent living is not impossible. Moderate. The patient is unable to remember basic personal details, and independent living is very difficult. Severe. Close relatives and faces are unrecognizable, and new information is difficult to retain. Additionally, neurophysiological or cognitive tests must show evidence of decline in cognitive ability, which is defined by deterioration of judgment, thinking, and processing of information. Again, this can come under the following categories. Mild, the patient's life is disturbed, but they're still self-reliant. Moderate, daily activities are increasingly difficult and the patient has to rely on others. And severe, there's an extreme difficulty in forming new ideas and concepts. The DSM-5 is more recent and is also known as Diagnostic and Statistical Manual of Mental Disorders. It differs from the ICD in that it originated from and is approved by the Assembly of the American Psychiatric Association, while the ICD has global influences. Here, dementia is classed as a neurocognitive disorder, or NCD, and includes impairments related to learning, memory, and visual perception. Listed here are the criteria needed to be met before you can diagnose someone with mild or major NCD. Both require symptoms to not be primary symptoms of another mental disorder. Additionally, both need evidence from a trustworthy witness, such as a family member or clinician, of neurocognitive decline, the difference being that major NCD would show a more significant decline. Major NCD also differs in that it is more impactful, and the individual cannot live independently and needs greater assistance. The DSM-5 outlines 6 domains that, should they be affected, are warning signs for major or minor NCD. Complex attention is related to paying attention to multiple or selective stimulus for an extended period of time, such as watching multiple people on TV or listening to multiple people in a conversation. Executive ability is about decision-making, responding to feedback, and forming habits. Warning signs could include loss of initiative and judgment and forgetting habits. Learning and memory links to long and short-term memory, and language includes grammatical ability and fluency. If affected, a patient might find it difficult to speak concisely. Deteriorating visual perception and motor skills can present itself in difficulty of picking up objects, driving, or using instruments. Social cognition is related to emotional and behavioral regulation, and red flags can include being socially withdrawn or oblivious to social cues. There is currently no cure for dementia, as it is usually the result of multiple varied factors. Instead, efforts are mostly focused on improving quality of life as a dementia patient and prevention of dementia. There is medicine available that can minimize symptoms. Donepezil, for example, and galantamine are used to treat moderate symptoms of Alzheimer's disease by increasing levels of chemical messengers related to memory. There is evidence that this can treat similar symptoms of Parkinson's disease dementia or Lewy body dementia. Alternatively, medicine targeting issues that can link to dementia, such as strokes or diabetes, can also be used. Over time, most dementia patients will develop BPSD, or behavioral and psychological symptoms of dementia. These include, but aren't limited to, mainly anxiety, hallucinations, and irritability. At this point, coping mechanisms to improve well-being can be incorporated into the patient's plan to avoid distress. If needed, antipsychotics, antidepressants, or other similar treatments can be prescribed. However, it is important to note that treatment should revolve around each individual patient. For example, medicines such as risperidone or haloperidol for schizophrenia should be used with caution, as they have strong side effects and should be used in low dosages. CST, or cognitive stimulation therapy, is also a possible option geared at people with mild to moderate symptoms and uses a form of group therapy to improve cognitive skills. At a more advanced level, cognitive rehabilitation involves a patient working alongside a trained professional to form habits and mindsets to help cope with the later stages of dementia. One of the most prominent symptoms of dementia is loss of memory and mental capacity. This, alongside the distress that often accompanies illness, thus leading to conflicts between carer and patient, often gives way to a plethora of medical ethical concerns. With the average life expectancy steadily increasing, it's vital we look into these issues to prevent or minimize their effects in the following years. To briefly recap, the 4 ethical pillars in medicine are autonomy, non-maleficence, beneficence, and judgment. Autonomy is upheld by ensuring the patient makes the decisions regarding their care. Non-maleficence is the practitioner's responsibility to ensure the patient is kept away from harm and neglect, and is closely linked to beneficence, which is the practitioner's need to act morally and in the best interests of the patient. Justice is upheld by ensuring fairness and making sure healthcare is equally accessible to all. The following case is taken from a series of interviews regarding ethical dilemmas between caregivers and patients. The names have obviously been changed to keep anonymity. Miss I was a dementia patient who lived at home and had her daughter take care of her with the help of a professional caregiver who visited occasionally. However, the two weren't often in contact, and therefore the professional caregiver faced a dilemma when Miss I refused to wash herself, saying it wasn't necessary. The professional caregiver doubted this, but said she felt it would be disrespectful as she wasn't around Miss I as much and wasn't as used to her behaviours if she followed her to the bathroom to help her wash. Well, of course, there are other issues here, such as a lack of communication and a set, clear care plan. We see the caregiver face a decision of whether to prioritise autonomy or non-maleficence. Hypothetically, if they had chosen to prioritize autonomy, they would accept Mrs. I's words and continue their chores. Later in the interview, it was, however, revealed that the patient had a history of urinary tract infections, suggesting that Mrs. I's behavior was commonplace. If repeated, this could have led to further health complications, and additionally, others could have commented on her hygiene, possibly worsening her emotional state. If instead non-maleficence was more valued, the caregiver would likely insist on following her to the bathroom, causing Miss I to likely feel insulted, untrusted, and ignored. If the caregiver was instead able to persuade Miss I to wash, this would have the more desirable outcome of preventing infection and promoting good well-being, which arguably justifies overriding her wishes and is less likely to cause as much conflict. While there is no perfect solution, this could have been entirely avoided by a collaboration between the daughter and the caregiver, so they could work to solve this issue together. As the daughter was around Miss I more, it's likely she would have had a better understanding of Miss I and know best how to act. In another interview from the same study, a different type of issue occurred where autonomy between patient and family caregiver were both conflicting. So after a critical incident, Mr. A was referred to okay, one moment. Okay, Mr. A was referred to placement in a care home, a decision made purely by his wife without his knowledge. On the day of his transport, he angrily grasped at her wrists and questioned her. His wife used this incident to evidence that he needed to be taken to a SCU, or specialized care unit, and showed bruises that formed as a result. Later, she admitted she had previously promised him she could live at home, therefore lying to him, and also that caring for him left her exhausted. She was desperate for a break and felt that she alone couldn't care for him the way he needed to be cared for. What's happened? Okay. Yeah. The underlying theme here is one that causes ethical implications in many scenarios involving a family caregiver. While they often are more familiar and more able to emotionally care for a patient, they're rarely as equipped for physically caring for a patient with dementia. Specifically regarding this case, it can be declared that its cause was likely Mr. A being frustrated at being denied the right to choice autonomy, and therefore the inability to give valid consent. Facing an abuse accusation from his wife must have made it worse, especially considering the interviews had also revealed they weren't on particularly good terms. Mrs. A, on the other hand, said she felt burdened with responsibilities and guilt, and felt it threatened her autonomy and well-being, as she had little time for herself, and being overworked and frustrated leads not only to a decline in well-being, but also in the patient's quality of care, as we see here. Mrs. A was so strained by her responsibilities that she made a decision she thought would be best for Mr. A, but instead had the opposite impact. I can't remember the study itself, but I think what they ended up doing, the staff at the professional staff, they ended up taking Mr. A to the specialized care unit and tried to make him see Mrs. A's point of view. So they decided to more so side with prioritizing Mrs. A's autonomy, and I think, yeah, that's where we finished. That's it from us. Yeah.
Thank you. That was a great presentation. I loved it very much. I wrote a lot of notes out of it. Before I pass it on to Dr. Kavita, there are two questions here. So the first question is, how does Alzheimer's, dementia, and Parkinson's differ? If you guys could answer, or if you can't, maybe Dr.
Yeah, I think because we had other people designated to each section, other people did deal with that more.
All right, no worries, that's fine. Is it okay if Dr. Kavita can answer for us, please?
Yeah, so the question is how to differentiate Alzheimer's from, is it Parkinson's?
From dementia and Parkinson's, yes.
Parkinson's, yeah. So basically both are could be age-related disorders. So it's important to differentiate. The main feature in Parkinson's is the area of the brain that controls motor skills, especially the fine motor skills and balance is affected. So although they still may have some level of cognitive impairment, the main things are seen in motor domain, which is like tremors. They have more of balance issues, movement issues, tremors, and all the fine motor skills will be affected. So you need to do a full neurological examination when people have those cognitive impairments to say what else is um, not functioning really well. And if predominantly they are having motor problems, then it's unlikely that it is Alzheimer's on its own. It's more like predominantly motor symptoms indicates it is Parkinson's.
Yeah, thank you for that answer. That was great. We have one more question, and that I think the speakers can answer this potentially, but it's based off the ethics, I'm guessing, of Mr. A, that patient. So the question is, what does a professional look for when determining whether a patient is psychologically unfit, in the sense, I'm guessing, that their autonomy would be disregarded, I'm guessing?
I think in terms of capacity, that's always kind of measured, I think, as far as I'm aware, before any large decision is made. And those are usually done with, again, if any trusted source has a reason to think that the person might not have any capacity or the ability to give informed consent, then they would say so. But other than that, I think there are just mental tests and neurophysiological tests to check their processing skills and how well they can function, I think, and memory and stuff like that.
Sure. Thank you. Yeah, hopefully that was adequate for whoever asked the question. Next, I introduce Dr. Fasanur again for her comments. So please go ahead.
Yeah, thanks, Aryan. And well done to both the speakers. It's an excellent presentation, really covered all the topics, a broad range of topics, and went into in depth with especially around the signs and symptoms, the etiological factors. So really enjoyed. If it is okay, I would like to just pick your brains on helping you to think with a couple of questions. You've mentioned about the ethical aspects, which is really important. So have you ever considered anything that might happen in terms of legal issues arising from dementia? Or anyone from the group could probably answer, if not the speakers. So.
I personally, I attended a work experience, and they showed a patient consultation where it wasn't dementia, but it was to do with memory loss. The patient had memory loss, and you kind of got the idea that the daughter was a lot more concerned with whether he was legally fit to change his will in order to include her in kind of who got money and stuff like that. But so yeah, in that sense, I think the main conclusion was obviously not to be rash with any judgments you make. You can't outright assume a patient has ulterior motives. A patient's caregiver has ulterior motives, but at the same time, I think it's generally referred to someone else. I think once if a GP in that scenario decides that it's kind of above them, it tends to be passed on to more people who are well versed with legal aspects of stuff, I think.
Could I just add, I do believe it goes to the lasting power of attorney. I think they do, if the patient allows them to take decisions on their behalf, so they can like put someone else forward, for example, that may be a family member, but that has to go through the lasting power of attorney. Yeah.
Good. Very well done. I think, yeah, you've covered both. In the presentation, you have mentioned about capacity, and that is one of the frameworks. So during those decision making around specific issues around treatment, around placement, who can support the person, and whether the person supporting the patient is working on their best interests, those are really tricky scenarios on a day-to-day practice for us to manage. So but to assist clinicians, there are a number of frameworks that we can use, like you've mentioned, the Mental Capacity Act. There's a formal assessment of capacity. You can assess capacity for individual decisions because capacity is highly specific to that particular decision. They may not have capacity to make a decision as to where they would want to live, but they may be perfectly having capacity on where they would like to spend their money. So assessing capacity is really important. And if someone if as a clinician you feel that someone doesn't have capacity, then you have to take all possible measures to improve their capacity by bringing someone that they can trust or things like that. And thirdly, there are other frameworks that can help you legally to make decisions that can help you as a clinician in managing the care of a person. For example, there is a best interest framework, and like Mena's mentioned, so lasting power of attorney, or there are frameworks which help patients develop advanced directives. When they have got better capacity, they can almost predict and give an advanced directive as to how they would want their care to be in future. So yeah, so as clinicians, there are lots of things that you can pull out in helping those decision makings and planning care. So that's good. One last question for the team, if it's okay. You've briefly mentioned about the differential diagnosis of what else you need to consider when someone is presenting with early signs of dementia. Have you ever heard about one particular differential diagnosis, which is called acute confusional state or delirium?
I personally haven't. No.
Neither have I, unfortunately.
Okay, that's okay. So if it is a first presentation, obviously you've mentioned about GP going through all the screening, but for someone to have had at a starting point to say, yes, this is the onset of dementia, there is a critical period where you have to rule out other causes. And one of the key things you've mentioned in your presentation is, but you haven't mentioned this term as delirium, but you've covered it in ruling out. Someone may present with confusion because of physical health issues like hypoglycemia. You've mentioned low blood sugars. Another common condition in elderly is urinary tract infections. So when they have infection, they may not overly come up with lots of signs of infection, but they may present with confusion, memory loss, disoriented, and complete change in behavior. So you have to rule out physical causes first before you think it is neurological, neurocognitive. So constipation, urinary tract infection, low blood sugar are again very common causes of onset of what looks like a confusional state. But if you treat the cause, they are back to their original self. So it's really important to categorize that as physical or acute confusional state. It has got a specific term which is called delirium. So it's one of the interview questions for us is exam questions is how do you differentiate dementia and delirium? So it's good to keep that framework as well. So well done. Really, really good presentations. Like I said, very thorough, very comprehensive and elaborate, and really excellent way of presenting as well.
Thank you for your feedback, Dr. Kavitha. Next up, we have Group 2 who will be presenting about schizophrenia. So good luck.
Hi, I'm just going to get the PowerPoint up now. It might take me a little minute. I've got a bit of slow Wi-Fi today. Sorry about that, guys. Hey, can you all see the PowerPoint? Is that okay?
Yeah.
Yeah.
Cool, perfect.
Okay, so hi everyone. Our presentation is, as was said, Schizophrenia, and it's by Tabby, me, Sri, and Sarah. So what is schizophrenia? So we can split the word up into two and look at its literal meaning. So schizo means split and phrenia means mind. So that can be easily confused with split personality disorder, but instead it generally describes how schizophrenia patients usually show a fragmented pattern of thinking. It's a severe long-term mental disorder which approximately affects 14.5 out of 1,000 people and is more common in men than women. It's a type of psychosis which means that someone with schizophrenia has trouble distinguishing between their reality and their own thoughts. This is often presented in hallucinations and delusions.
Schizophrenia involves a range of problems with thinking, behaviour and emotions. Signs and symptoms may vary, but usually involve delusions, which are false beliefs and not based on reality, hallucinations, which involve seeing or hearing things that don't exist, or disorganised speech, and reflect an impaired ability to function. Symptoms may be positive or negative. Positive symptoms are when you experience things in addition to reality. For example, you might see, hear, or believe things that others don't. Negative symptoms are when you lose the ability to do something. For example, losing motivation to do things or becoming withdrawn from friends or family. They often last longer than positive symptoms. For some, schizophrenia can develop during young adulthood and develop slowly. The early stage of the illness is called the promodal phase. During this phase, your sleep, emotions, motivation, communication, and ability to think clearly may change. In men, symptoms typically start in the early to mid-20s. In women, symptoms tend to begin in the late 20s. Although there are no lab tests to specifically diagnose schizophrenia, the doctor may use various diagnostic techniques, such as MRI or CT scans or blood tests, to rule out physical illness as the cause of your symptoms. If the doctor finds no physical reason for the symptoms, they may refer the person to a psychiatrist or psychologist, who will use specially designed interview and assessment tools to evaluate a person for schizophrenia.
So etiological factors. This is basically the cause or origin of a disease. And for schizophrenia, it's not known for certain what the causes are. However, there are quite a few environmental and genetic factors that are believed to contribute towards the condition. So the first one is genetics, and research shows that those who have a history of schizophrenia in their family have a higher risk of developing it, which was seen in a well-known study on twins, where out of a set of identical twins, there was one twin who had schizophrenia, and it was found that the other identical twin had a 50% chance of developing the disease compared to the 1% chance that the general public have. It's not known for certain which genes cause schizophrenia, but scientists believe that it's a combination of genes rather than a single specific gene. There's also a link to trauma and schizophrenia, as those who have traumatic pasts are more likely to develop schizophrenia. This is believed because many people have hallucinations related to their past trauma, and there's also evidence that a lack of parents in a child's life, whether this is due to separation or death, can also lead to a higher chance of developing the disorder. This factor is also quite unknown, as it's unclear whether it is causation or just a correlation. The next factor is pregnancy and birth complications, where a child has a higher chance of developing schizophrenia if there were complications before or during their birth. These complications can include low birth weight, infection during pregnancy, and asphyxia, which is a lack of oxygen when the child is being born. This factor is also not fully understood, as there are some ethical concerns with doing research studies on pregnant women. Then there are also quite a few changes within the brains of people who have schizophrenia, and researchers have found that those who have schizophrenia have many structural differences compared to the general public. These differences can include a smaller volume in the hippocampus, amygdala, thalamus, and intracranial spaces, and a larger pallidum and ventricle volumes. So in the image, we can see that the brain scan on the left is the typical brain MRI scan, and the brain scan on the right is a brain scan of someone with schizophrenia. And we can see that the structure in the middle, the dark like butterfly shape, is quite enlarged on the brain on the right. And this shows the larger ventricle volumes. There are also quite a few chemical changes, and research has shown that certain certain drugs that block dopamine receptors in the brain and result in less dopamine in the neurons have been effective in managing schizophrenia. This leads to doctors believing that schizophrenia can be a result of increased dopamine levels, and there have been links found to other neurotransmitter systems like serotonin. Finally, it's believed that while drugs such as cannabis, cocaine, and LSD don't cause schizophrenia, they can trigger the symptoms of schizophrenia in someone who is at high risk of developing it. So due to the varying presentations of schizophrenia, there are multiple criteria available for doctors to help with the diagnosis. You have the DSM-5, which is the Diagnostic and Statistical Manual for Mental Disorders, which is the 5th edition, and the ICD-10, which is the International Classification of Diseases, the 10th revision. Both criteria talk about the same kind of symptoms. So these are delusions, hallucinations, catatonic behavior, and they both say that patients need to have the same kind of general time requirement for the onset of these symptoms. And they both state that the symptoms must not be a result of other health conditions or substance abuse. The DSM criteria does have a couple of differences compared to the ICD criteria, in the sense that it kind of gives guidance for a wider range of scenarios. For example, we can see on the table that there's guidance for diagnosis if a patient has a history of autism, and both are quite useful for doctors, but we can see that the DSM criteria is slightly more extensive.
So there are a number of different disorders that may be kind of confused with schizophrenia, because lots of the symptoms are kind of the same for a few of them. So, for example, drug-induced psychosis, which is caused by the substances listed on the PowerPoint. There's some recent research that suggests that smoking high-potency marijuana every day could increase the chances of developing psychosis by nearly 5% compared to people who have never used it before. The strongest evidence for this is based on genetics. So if you've got specific genetic vulnerabilities due to specific variants of the AKT1 gene, for example, and then you're more likely to develop psychosis as a result of taking cannabis. However, marijuana often produces an acute psychotic reaction in non-schizophrenic people who use marijuana, especially at high doses, although this fades as the drug wears off, hence indicating it's not schizophrenia. Patients who take these drugs also often present with neurological problems such as paranoia, irritability, and depression, which can be easily confused with schizophrenia. You've also got sepsis. Sepsis-associated encephalopathy is characterized partly by disorganized thinking and impaired attention, so it might be confused with schizophrenia. However, other symptoms of sepsis, although not all of them are always present, differentiate sepsis and schizophrenic patients pretty rapidly. So some of these symptoms are a rash that doesn't fade when you roll a glass over it, so the same as meningitis, and breathlessness. It can also be, schizophrenia can also be confused with other underlying conditions such as cerebral tumours, cerebrovascular disease, and temporal lobe epilepsy. Personality and behaviour changes are most common when a tumour is located in the frontal lobe of your brain and also the temporal lobe. And the frontal lobe controls your personality, emotions, and also your ability to regulate behaviour and restrain yourself. So it can cause abnormal and atypical behaviour for that person, similarly to schizophrenia. Based on other manifestations of cancerous symptoms, it should be relatively easy to differentiate between the two. It's said that 1 in 3 people the brain tumour charity spoke to had experienced personality changes caused by a brain tumour or its treatment, so it's certainly a consideration when tracking neurological behaviours. You've also got PTSD, which can include flashbacks of a hallucinatory quality, and it's distinguished from psychotic disorders based on the existence of a traumatic event in the past. Severe affective mood disorders associated with psychotic symptoms include severe depression or bipolar disorder, and they are distinguished from schizophrenia by the predominance of affective symptoms that may at times trigger psychosis. which is contrasted by schizophrenia, which is dominated by psychotic symptoms that may at times be associated with affective symptoms. You also have OCD, where strong irrational beliefs are withheld, but this is usually related to a specific fear, and rituals are developed, so you can separate it from schizophrenia as well. You've also got autism spectrum disorder or communication disorders, and these people with these disorders may display symptoms that resemble a psychotic episode, but they're distinguished from schizophrenia by their deficits in social interaction with repetitive and restricted behaviours. Essentially, schizophrenia is a difficult disorder to fully understand because the symptoms can point to a litany of other conditions, as well as lots of conditions within medicine. This often makes treatment delayed by a number of years before patients will receive care. There are lots of treatment options for schizophrenia, although it cannot be cured. So based on the type of prodrome you have, your doctor will come up with a treatment plan that can best help you. And a prodrome is essentially the time between the onset of symptoms and full-on psychosis. This can be days, weeks, months, or even years. Most people are treated by community mental health teams, which is CMHTs, which provide day-to-day support and treatment while ensuring the patient has as much independence as possible. And they're often made up of a number of healthcare professionals, such as social workers, community mental health nurses, who have specialist training in mental health conditions, and psychiatrists, who usually are the senior clinician in the team. This is a classic example of a multidisciplinary team supporting a single patient. So people with complex mental health conditions are usually entered into a treatment process known as a care program approach, which is a CPA. You've got 4 stages of this, which is assessment, care plan, a key worker is appointed, which is usually a social worker or a nurse, and is the first point of contact, and reviews. So the treatment plan can constantly evolve based on how the patient is feeling and developing. With acute episodes, and this is people who have serious psychotic symptoms as a result of an acute schizophrenic episode, may require a more intensive level of care than a CMHT can provide. And this is usually dealt with antipsychotic medication and special care by a CRT, which is a crisis resolution team. These aim to treat people at home and not in hospital, while also planning aftercare once the crisis has passed to prevent a further crisis occurring. It's very important that throughout the patient's care they feel supported and aided, particularly with an unstable condition such as schizophrenia, which can relapse easily and quickly. So voluntary and compulsory detention is used in more serious acute schizophrenic episodes. So it may require them admission to a psychiatric ward at a hospital or a clinic. A patient can admit themselves voluntarily to hospital if the psychiatrist agrees it's necessary, and people can also be compulsorily detained at a hospital under the Mental Health Act of 2007, but this is very rare. It's only if in the interest of the person's own health and safety and to protect others. An independent panel will regularly review the case and progress, and once they feel the patient is no longer a danger to themselves and others, they'll be discharged from hospital. Advance statements can also be really useful. They're essentially a series of written instructions about what the patient would do and would like their family and friends to do in case they experience another acute schizophrenic episode. They may also want to include contact details for their care coordinator, so there's always someone professional on hand to help out. You've also got antipsychotics, so we've got some drugs. These are usually recommended as the initial treatment for the symptoms of an acute schizophrenic episode, and they work by blocking the effect of the chemical dopamine in the brain. It can usually reduce feelings of anxiety or aggression within a few hours of use, but may take several days or weeks to reduce other symptoms, such as hallucinations. This can be taken orally as a pill or an injection known as a depot. Several slow-release antipsychotics are available, such as aripiprazole, via an injection every 2 to 4 weeks. Most people, however, take medication for 1 to 2 years after their first psychotic episode to prevent further acute schizophrenic episodes occurring. There are two main types of antipsychotics. You've got typical and atypical antipsychotics, and it's really important that a discussion happens between a patient and a psychiatrist, so they can go through the potential side effects of both. For example, muscle spasms, which are more typical with typical antipsychotics, and weight gain for atypical antipsychotics. And this medicine should be reviewed at least once a year. Finding the treatment plan is based mostly around the idea of the autonomy of the patient, who has informed consent from trained healthcare professionals such as psychiatrists to find a treatment plan that really works for them and gives them the best chance of a normal life. Psychological treatment can help people with schizophrenia as well, cope with the symptoms of hallucinations or delusions. So this can be CBT, which is cognitive behavioral therapy, family therapy, and art therapy. So CBT can help you really focus in on your delusional thinking, for example, and help you address those problems and what you do and coping mechanisms. Family therapy gets the whole family involved so you feel more supported and they can understand your condition. And arts therapy has been shown to alleviate the negative symptoms of schizophrenia in some people. Teens and young adults who may have mild symptoms of schizophrenia may also do well with antidepressants. So at the moment, there's no cure or no known cure for schizophrenia, but the outlook for people with this illness is improving. Many ways to treat and try and reduce the symptoms associated with schizophrenia, including medication, psychotherapy, behavioral therapy, and social services, as well as employment and educational interventions. Therefore, multidisciplinary teams become increasingly important to support individual patients. So how long does schizophrenia last? 10 years after diagnosis, 50% of people with schizophrenia are either recovered or improved to the point that they can work and live on their own. 25% are better but need help from a strong support network to get by. 15% aren't better, and most of these are in hospital. So there are a number of things that can affect the outcome and the risks. So you've got how well you did in society and at work before your schizophrenia began. So essentially your personality and your social skills previous to your condition, and the amount of time from the start of symptoms to diagnosis and treatment. So this is the prodrome. The sooner you're treated for schizophrenia, once symptoms begin, the more likely you are to improve and recover. So the average length of time between the start of psychosis and the first treatment is around 6 to 7 years. There's also certain risk factors as well, such as a family history of schizophrenia, and there are some pregnancy and birth complications such as malnutrition or exposure to toxins. And then you've got taking mind-altering drugs during teen years and young adulthood, and these can be psychoactive or psychotropic. So yeah, there are some potential complications which have quite a significant impact on the patient's life. So 3 we'll talk about later: suicide. We've also got anxiety disorders and OCDs, depression. So schizophrenia is often linked to other mental health conditions. You've got abuse of alcohol or other drugs, including nicotine, and this varies from patient to patient, particularly if the patient suffers with addiction that causes psychosis. You've also then got lots of socioeconomic, financial problems. Maybe they're homeless, maybe they can't work or attend school. Social isolation because of their condition, and also health and medical problems as a direct result.
So as Tabby said before, there are quite a few social issues that are a result of schizophrenia. So the symptoms of schizophrenia can make it quite difficult for patients to socialize and build relationships that are out of their family relationships. So symptoms such as delusion and hallucinations can make it quite difficult for patients to gain a real sense of reality. And then due to a combination of these symptoms and some of the misconceptions that people have about schizophrenia, many people assume that schizophrenic patients are quite violent and therefore dangerous, but this is not always the case, and many people suffering with schizophrenia are not actually violent. It's usually those with symptoms that are directly associated with violence that begin to behave this way. So one of these symptoms could be delusions of being persecuted. And both of these factors can result in schizophrenic patients struggling to maintain a career, and this can result in them struggling to sustain themselves, which means they may have to rely on benefits and other schemes. And these factors also contribute to the high suicide rate for schizophrenic patients. And the suicide rate is actually 20 times higher for those with schizophrenia than the general population, which is unfortunately very high.
So I've very briefly explained the 4 pillars of medical ethics on the slide, but I'm sure most of you are quite familiar with them by now, so I'll just jump into the application. So schizophrenia may also impair one's ability to meet one or more of the key components of informed consent, such as the capacity for decision-making and voluntariness. Although loss of capacity is by no means a given for patients with schizophrenia, it may be that it's still associated with diminished capacity to make certain kinds of decisions, especially if the decision intersects with specific delusional ideas. From an ethics perspective, the principles of autonomy and truth-telling may sometimes conflict directly with the principles of beneficence and non-maleficence when working with patients with schizophrenia. So half-truths may conflict between truth-telling and doing good. The conflicts between truth-telling and doing good may be faced by any psychiatrist who considers withholding information from a patient regarding their likely psychodynamics or utmost underlying emotional needs. If a psychiatrist reframes how a patient regards their heightened paranoid thoughts so that they see thoughts as possible strengths, this may enable the psychiatrist to build a stronger patient alliance, which may in turn help the patient feel less isolated and alone. Sorry, Tabby, can you go to the next slide, please? So early detection and prevention. Among the most important developments in the care of people with schizophrenia spectrum disorders within the past decade are models for screening and detecting individuals in early stages and the identification of treatment interventions for slowing or preventing further progression of the disorder and maximising treatment response. However, comprehensive care for people with early stage disorders who may not meet the full criteria for schizophrenia remains limited. So advances in scanning have allowed researchers for the first time to show lower levels of a protein found in the connections between neurons in the living brains of people with schizophrenia. The researchers who conducted the scans at the Psychiatric Imaging Facility at the Medical Research Council, London Institute of Medical Sciences, scanned 18 adults with schizophrenia and compared them to 18 without. The researchers detected this in living brains for the first time by utilising a tracer that emits a signal which can be picked up by a PET brain scan. After being injected, the tracer binds specifically to a protein found in the synapses called the synaptic vesicle glycoprotein 2A, which has been shown in animal and post-mortem studies to be a good marker of the density of synaptic nerve endings in the brain. They found that levels of the synaptic protein were lower in the front regions of the brain, which often involved in planning. Current treatments for schizophrenia only target the psychotic symptoms of the disease, but the debilitating cognitive symptoms often cause much more long-term disability, and there's no treatment for them at the moment. Synaptic loss is thought to underlie these symptoms. This protein could be a target for new treatments to restore synaptic function. So, whilst several antipsychotic drugs are currently on the market, none have been a solution to fighting the distortion in thoughts, hallucinations, and feelings of fright associated with schizophrenia. About 30% of people who take medication may experience a relapse. So lumateperone is an atypical antipsychotic medication that's used for the treatment of schizophrenia in adults. It's taken as 1 capsule per day, and the medication is believed to act as an antagonist on certain serotonin and dopamine receptors. In clinical trials, the drug was shown to improve symptoms of schizophrenia. It was first approved by the US FDA for the treatment in December of 2019 and has been investigated in acute or residual schizophrenia, bipolar depression, and other neurological and psychiatric conditions. Drug development for schizophrenia may be entering an interesting new era because a number of new drugs currently under study are not new variations of dopamine receptor blockers. Recently, a study was published on a new compound produced by Sunovion Pharmaceuticals, which is thought to interact with the trace amine associated receptor and the serotonin receptor, but not with dopamine receptors. In the 4-week study, there was a significant improvement in symptoms of psychosis, but no apparent differences from placebo on metabolic measures or involuntary movements. The following table on the next slide includes several other compounds that are currently being studied and which are not dopamine blocking drugs. Thank you for listening.
Thank you so much, Group 2. That was really, really informative, and I really enjoyed that. So I'm going to pass it on to Dr. Kavitha to give her feedback. So I'll hand it over.
Thanks, Amita. Yeah, I agree. Really enjoyed the presentation. Very thorough. Covered all the important topics. I don't know if there were any questions on the chat or
No, not for the speakers.
not for this. Okay. If that's okay, I might just pick your brains for the presenters in thinking about. You've mentioned about the signs and symptoms. Schizophrenia, there is always it is useful to look into the history of the condition, because you've mentioned where the name came from, which is schizo and then the phrenia, and explained around that. One of the things when we talk about signs and symptoms, it would be useful to look into the first rank symptoms, and they are Schneider's first rank symptoms of schizophrenia is always good to look into, and that would be useful in terms of thinking about the presentation as well. One question is, what would be useful from clinical perspective during the diagnosis? You've mentioned about delusions, hallucinations, the thought process, evaluation. In day-to-day clinical practice, what do you think can help clinicians assist clarification on, is it a delusion or is it a truth? Can you think about what might
Sorry. I think that it would be helpful for clinicians to kind of like differentiate between whether they are actually having delusions or whether it's just the way they're perceiving reality. I think it would be helpful if they kind of got some history in terms of how they usually kind of see everything. So comparing what their life would be like, the way that they kind of interact with their surroundings and with people before the symptoms, and then kind of comparing that to how they are kind of acting and reacting now that they think that they have symptoms of delusion. And then kind of getting some feedback from close family members or close friends to see if they've noticed any changes. And I think it's kind of, if a patient is saying something which is obviously very like different to reality, so kind of seeing spiders like or crawling on the walls, things like that would be giveaway signs that they're having some quite like powerful delusions.
Excellent, really good. Yeah, you've covered everything. Someone has come to my clinic and says, oh, my neighbor has planted cameras around my house. and they will give that history in a very convincing way to me, and it is for me to analyze why would the neighbor do it, and what evidence is there if the neighbor has really done it, and why does the patient think so. For us to unpick those other things, collateral history and change in functioning. So yeah, very well answered. Good. I don't have any more questions. I'm happy to feedback if no other questions.
Actually, there is one question for you. So it asks a question for Dr. Kavitha. What kind of things does a professional look for when determining whether a patient is psychologically unfit?
So we don't usually use the term psychologically unfit. So I'm assuming that the question is around capacity. So again, it goes back to, for a person to have capacity or not, there are 4 key components that are to be assessed. So first of all, does the person have the ability to register what you're saying? That means you're giving them some information. Are they able to actually register? After registering, the next one is retain. They have to register it, but also retain it for a period of time where they can actually engage with you in that thought process and communication. So register first, retain that information, and the next step is they have to then balance the risks and benefits of the key decision. So what are they choosing? Whether they are choosing to consent or refuse, whatever that may be. So the next one is they have to weigh up the pros and cons of that decision. And the last bit is then they have to communicate what they have thought about in a way that they can put a fair argument to you as a clinician to say why they think, what made them to come to that decision. So those are the 4 key things: registration, retention, balancing the choices, and then communicating the choice with the risks and benefits of their decision making. So if all of those 4 elements are present, then the person has capacity, which I'm assuming is what you're thinking as psychologically fit. If any of those components is not um, evidenced in your assessment, then you can say that the person doesn't have capacity. So either they are not able to register, they might be under the influence of drugs, alcohol, and they are completely zoned out, they can't register, then they don't have capacity. Even if they register, but they can't retain it for a fair period of time to engage in that decision making conversation, then they don't have capacity. Or if they can register and retain, however, they can't think of pros and cons, then they don't have capacity. And even if they have pros and cons, but they can't communicate to you, then they don't have capacity. So there are loads of reasons why people may not have capacity, like they might have serious mental illness, people with learning disabilities whose IQ may be very low, that they can't process information, register, retain, and like some of the disorders that we have discussed, like dementia, schizophrenia. So they all might, like I said, the capacity and decision making is specific to every individual question. So a person may have capacity for one, but may not have capacity to another. So you need to assess capacity for every single thing. If you want to admit someone, you can assess capacity. After admission, if they refuse treatment, again, you have to assess capacity. So every stage needs a capacity assessment. Hope that makes sense.
Thank you. That was a great answer once again. So I'll also thank you to the speakers for their wonderful presentation. Again, I've made quite a lot of notes from that. So now I'd like to introduce everyone's favorite part of Mediccom, lunch. So it is now 12:05, and at 12:55 we will come back and have group 3, which will be, let me check again, group 3, which is anorexia and bulimia. So once again, another big thank you to Dr. Kavita for being here, and hopefully I think she'll be here for afterwards too. So that would be great. And also another big thank you to Health for Curriculum for collaborating with us. Their Just Giving page will be on the stream. You'll see a countdown timer, and above it will be the link to their Just Giving page. We'll try to put it in the YouTube description too. Okay, right. Thank you, and see you all at 12:55.
Okay, welcome back, everyone. I think we should be ready to come back together now. So hope you've had a good lunch. I just wanted to make some announcements just to remind you of what we mentioned at the beginning of the event. It would be great if you could all go onto Google, type in Mediccom Healthcare Society, and you'll get a Google business page, as Arian has shown us before, where you can write a review about Mediccom, which would be really useful, because if you did, we could branch out to more people, we could gather a larger audience, more doctors, more, a larger judging panel. It would be great for us in the future, and he's just put that link in the chat box there. So that's one of the things. The other thing is you could, if you could also follow our Instagram account. It is Mediccom Healthcare Society on Instagram. We have been posting all about our events, but we also want to add some new features. So if you do have any ideas for that, please let us know. We could help out with the UCAT. We could give advice on the BMAT. We could also, if you have any more ideas about A-levels or anything that you would like us to give some tips on, that we would be more than happy to do that. And that's pretty much it. Also, we have a LinkedIn. You could follow us on LinkedIn. So all of those, and please do donate to the Health for Curriculum, who will the team will be coming to speak to us later on today. And of course, we have our guest speaker at the end of the session, who's going to talk to us about personal statements, which seems to be our big goal at the moment. So it'll be great to hear what they have to say. Apart from that, I think we're ready to move on to the next group. So I'm going to hand it over to group 3 whenever they're ready to present on anorexia and bulimia.
We're just trying to get the presentation up. So our presentation is on anorexia and bulimia. And we would like to give a trigger warning to anyone who might be triggered by the talk of eating disorders, and we are showing pictures of people that have suffered with anorexia and bulimia. Okay, so what is anorexia and bulimia? So let's start with anorexia. People who have anorexia try to keep their weight as low as possible by not eating enough food or exercising too much or both. This can make them very ill because they start to starve. They often have a distorted image of their bodies, thinking they're fat even when they're underweight. And men and women of any age can get anorexia, but it's most common in young women and typically starts in their mid-teens. And as for bulimia, people who have bulimia go through periods where they eat a lot of food in a very short amount of time, which is basically called binge eating, and then they make themselves sick by using, say, laxatives, which is basically medicine to help the excretion of feces, or they do excessive exercise, or a combination of these to try to stop themselves from gaining weight. Next slide, please. So, what are the symptoms of anorexia? So, there's lots of symptoms. So, there's missing meals, eating very little or avoid eating any foods that you see as fattening, lying about what and when you've eaten and how much you weigh, taking medicine to reduce your hunger. These are also called appetite suppressants, such as slimming or diet pills, exercising excessively, making yourself sick, or using medicine to help you defecate, which is basically laxatives, or to make you pee, to try to avoid putting on weight. So an overwhelming fear of gaining weight, strict rituals around eating, seeing losing a lot of weight as a positive thing, believing you're fat when you're a healthy weight or underweight, your period stopping. So obviously this happens in women, and there's poor circulation in hands and feet, dry skin, hair loss from the scalp, or fine downy hair growing on the body. Next slide, please. So what are the symptoms of bulimia? So there's eating very large amounts of foods in short time, often in an out of control way, which is also called binge eating, making yourself vomit, using laxatives, or doing an extreme amount of exercise after a binge to avoid putting on weight, and this is basically called purging. Fear of putting on weight, similar to anorexia, and being very critical about your weight and body shape, and mood changes. So these symptoms may not be easy to spot in someone else because bulimia can make people behave very secretively. Next slide, please.
Anorexia nervosa is most commonly known to affect the endocrine system, which contains glands and organs that produce hormones and deliver them into the bloodstream. Anorexia can lead to mainly abnormalities to do with the body. For instance, it can lead to a lower level of gonadal hormones, such as estradiol hormones, which mature and maintain the reproductive system, progesterone, which triggers the lining of the uterus to thicken, preparing to accept a fertilized egg, and anorexia can lead to low levels of testosterone, which helps with development, fertility, and muscle growth. Other abnormalities can develop, such as a reduction in the levels of triiodothyronine, which plays a vital role in maintaining the body's metabolic rate, heart and digestive functions, and muscle control, as well as reducing levels of thyroxine, which also controls the body's metabolic rate. Anorexia can also lead to an increase in cortisol levels and secretions, which are produced in your adrenal glands, therefore causing more stress for someone anorexic. Your menstrual cycle can also be affected, as menses could pause, and many women may suffer irregularities with how often their periods occur. Next slide, please. Bone mass can also decline as a result of anorexia. In several undernourished patients, it is common to see major organ systems being affected because of the lack of nutrition in their diets. However, this does not necessarily mean that the patient is more vulnerable to infections. As anorexia becomes severe, individuals can experience dehydration and metabolic alkalosis, which increases the body's pH levels and increases the serum bicarbonate concentration, which in turn causes the individual to become fatigued, nauseous, and can trigger an increase in anxiety and seizures. Vitamins and minerals, such as serum potassium and sodium, can also be at low levels in the body. In someone suffering with anorexia, these symptoms mainly arise from induced vomiting caused by the individual, the use of diuretics and laxatives, hypokalemia, which shows there is an extremely low level of potassium in the blood, and even hypovolemia, which happens when you lose a lot of blood or fluids from your body, and this can be life-threatening. The cardiac muscle mass, chamber size, and output could be affected and can cause mitral valve prolapse, where the mitral valve flaps into the left atrium during heart contractions and can cause palpitations and chest pain. One or both of the flaps may not close properly, and so this allows the blood to leak backward into the left atrium. Sudden death can also happen in severely anorexic patients when ventricular tachyarrhythmia occurs and causes a fast abnormal heart rate. Next slide, please. When it comes to someone suffering with bulimia, severe fluid and electrolyte disturbances occur. One of the most common examples would be hypokalemia, which, as mentioned before, leads to extremely low levels of potassium in the bloodstream. In very extreme cases, bulimia can result in stomach ruptures, or the esophagus could tear whenever the individual binge eats. This can be followed by more life-threatening complications further on in life. Since not a lot of weight loss occurs instantly, many of the physical complications linked with anorexia nervosa would not be present. Nonetheless, cardiomyopathy, which are diseases of the heart muscles which affect the heart's ability to pump blood, can transpire, especially from long-term abuse of syrup of ipecac, which is usually used in emergency treatment of specific kinds of poisoning, as it causes a person to vomit the poison out of the body. But someone suffering from bulimia may use the drug to expel any food or fluids from the body, which can make them malnourished as they have lost a lot of nutrients. Next slide.
So, how do you diagnose anorexia? If your doctor suspects that you have anorexia nervosa, they will typically do several tests and exams to help pinpoint a diagnosis, rule out medical causes for the weight loss, and check for any related complications. These exams and tests generally include a physical exam, so this may include measuring your height and weight, checking your vital signs such as heart rate, blood pressure, and temperature, checking your skin and nails for problems, and listening to your heart and lungs and examining your abdomen. Another test that can be done is a lab test, and these may include a complete blood count and more specialized blood tests to check electrolytes and protein, as well as functioning of your liver, kidney, and thyroid. And then a psychological evaluation may be done, where a doctor or mental health professional will likely ask about your thoughts, feelings, and eating habits. You may also be asked to complete psychological self-assessment questionnaires. And other studies, X-rays may be taken to check your bone density, to check for stress fractures or broken bones, or check for pneumonia or heart problems. Electrocardiograms may be done to look for heart irregularities. Next slide, please. How do you diagnose bulimia? So if your doctor suspects that you have bulimia, they will talk to you about your eating habits, weight loss methods, and physical symptoms, do a physical exam, request blood and urine tests, request a test that can identify problems with your heart, so an electrocardiogram, or they might perform a psychological evaluation, which includes a discussion of your attitude towards your body and weight. Next slide, please.
So the treatment for bulimia is slightly different for adults and those under 18 years old. So first I'll begin with the treatment for adults. So you'll be offered a guided self-help program as the first step in treating your bulimia, which often involves working through a self-help book combined with sessions with a healthcare professional, such as a therapist. And these self-help books take you through a program that helps you to monitor what you're eating, make realistic meal plans, learn about your triggers, identify the underlying causes of your disorder, and find other ways of coping with your feelings. And many people also join self-help support groups. Then there's also cognitive behavioral therapy. So if you're offered this, it will usually involve up to 20 sessions across 20 weeks. And this basically just involves talking to a therapist who will help you explore emotions and thoughts that could be contributing to your eating disorder and how you feel about your weight and body shape. And this will help you adopt regular eating habits and show you how to stick to them and how to manage feelings and situations. So the treatment for children and young people. So there's something called family therapy, and children and young people will usually be offered this. And it involves the patient's family and themselves talking to a therapist, exploring how bulimia has infected them and how their family can support them better. And they may also be offered CBT depending on the situation. And there's also medicine. So antidepressants should not be offered as the only treatment for bulimia, but you may be offered an antidepressant such as fluoxetine, Prozac, in combination with therapy or self-help treatment to help you manage other conditions such as anxiety or depression, social phobia, and OCD. But antidepressants are rarely prescribed for children or young people under 18, but yeah. And where treatment will happen for bulimia. So most people will stay at home during their treatment and you'll have appointments at your clinic and then you can go home. However, you may be admitted to hospital if you have serious health complications, including being very underweight, problems with your heart, being very ill and your life being at risk, being under 18 and your doctors don't think you have enough support at home, and doctors being worried that you might harm yourself or at risk of suicide. And then there's also interpersonal psychotherapy, which is used for adults or children and young people, which addresses difficulties in close relationships, helping to improve communication and problem-solving skills. Next slide, please. So this is treatment for anorexia. So treatment for anorexia usually involves a combination of talking therapy and supervised weight gain. So treatment for adults, again, CBT is offered. For anorexia, it usually involves weekly sessions for up to 40 weeks, 2 sessions a week in the first 2 to 3 weeks. And it involves talking to a therapist. And then there's also mildly anorexia nervosa treatment for adults, which also involves talking to a therapist in order to understand what's causing your eating disorder, and it focuses on what's important to you and helps you change your behavior when you're ready, and you're generally offered 20 sessions. Then there's specialist supportive clinical management, where you'll learn about nutrition whilst talking to a therapist and how your eating habits cause your symptoms, and you're offered 20 or more weekly sessions. Then there's focal psychodynamic therapy, which is usually offered if you do not feel any of the above therapies are right for you or if they don't work. And this understands how your eating habits are related to what you think and how you feel about yourself and other people in your life. And you're usually offered weekly sessions for up to 40 weeks. And during your treatment course, your doctor will probably give you diet advice on healthy eating and your diet, However, this alone won't help you completely recover from anorexia, so you'll need to have talking therapy as well as dietary advice. And doctors will probably advise you to take vitamin and mineral supplements so you get all the nutrients you need to be healthy. So, treatment for children and young people. So, like I said, for bulimia, they can be offered family therapy. So, usually be offered 18 to 20 sessions over a year. And then there's also adolescent-focused psychotherapy, which will involve up to 40 sessions and normally last between 12 and 18 months. And yeah, so you'll have therapy here. And you'll also have diet advice in children as well. And your doctor will give advice about the best foods to eat to stay healthy and tell you about which vitamin and mineral supplements you need to take. And then your doctor will also be checking your bone health because, like someone previously said, anorexia can make your bones weaker, which can make you more likely to develop osteoporosis. So because of this, your doctors may suggest you have a bone density scan to check the health of your bones. And girls and women are more at risk of getting weak bones than men, so your doctor may prescribe you medicine to help protect your bones against osteoporosis. And in anorexia, antidepressants may be offered in combination with therapy to manage other conditions such as anxiety, depression, social phobia. But again, they're rarely prescribed for children or young people under 18. And sometimes there has to be compulsory treatment because occasionally people with anorexia may refuse treatment even though they're seriously ill and their life is at risk. So in these cases, doctors may decide as a last resort to admit the person to hospital for compulsory treatment under the Mental Health Act, which is known as sectioning. And finally, it's important that you still receive ongoing support after your treatment is finished, so checkups. So you should have checks of your weight at least once a year, as well as of your mental and physical health, which will usually be done by your GP, but it could be done with your eating disorder specialist. Next slide.
Anorexia can have a lot of complications, and in some cases it can even be fatal. Death can suddenly occur even if the person isn't underweight. This may be a result of abnormal heart rhythms, arrhythmias, or ventricular tachyarrhythmias, or an imbalance of electrolytes, which includes potassium, sodium, and calcium, all of which are needed for balanced fluids in the body. And there are also many other complications such as anemia, heart problems, bone loss, also known as osteoporosis, loss in muscle. In females, there's also the loss of period. In males, there's a decrease in testosterone. There's also gastrointestinal problems such as bloating, electrolyte abnormalities, kidney problems, organ failure, and there can also be some psychological factors as well, such as depression, anxiety, personality disorders, alcohol and substance misuse, and self-injury and suicidal thoughts. Next slide. And when it comes to bulimia, there are also several other complications which can either interlink with anorexia but are also quite different, such as negative self-esteem and problems with relationships and social functioning. People with bulimia can also suffer from dehydration, which can lead to major medical problems such as kidney failure. There's also heart problems such as an irregular heartbeat or heart failure, similar to someone suffering with anorexia. There's also severe tooth decay and gum disease, absent or irregular periods in females. There's also digestive problems, anxiety, depression, personality disorders, or bipolar disorder. Same experience with someone suffering with anorexia as well. There's also the misuse of alcohol or drugs and self-injury, suicidal thoughts or suicide. So it's very common for someone suffering with anorexia and bulimia to have very similar psychological problems which can arise from both of these conditions. Next slide, please. Psychologists are also at the forefront of several innovative treatments for eating disorders that target hard-to-reach populations, such as adult women and those in rural areas. One example of this would be clinical psychologist Margot Main, who has a PhD and is the co-founder of Main and Weinstein Specialty Group, and is also working with older adult women with eating disorders. And she states that most of these women feel shame about their disorders and thinks that they should have outgrown such teenage problems through individual therapy. Main also helps validate their experiences as women by discussing the many cultural and societal pressures women face in terms of perfectionism and weight and shape. As you can see in the media, there is a lot about this as well. And she also encourages her clients to learn how to take time for themselves. Repetitive transcranial magnetic stimulation, RTMS, is a new treatment which is being trialled in the London Research Centre, and results from this project, led by psychiatrist Professor Ulrich Schmidt at the Institute of Psychiatry, Psychology and Neuroscience at King's College London, have been cautiously promising. Our brain imaging and behavioral studies also suggest that the way in which RTMS might work is by reducing the activity in the brain region, the amygdala, involved in anxiety and threat responses, and dampening the patient's emotional arousal, stress, and anxiety, says Smith. Neuronavigation also tells you whether you are in the right place or not. Next slide, please.
There are several ethical concerns associated with the eating disorders bulimia and anorexia, and these consist of breaches of confidentiality and uninformed consent. Statistics have shown that approximately 20% of claims made against counsellors in the past few years were due to breaches of confidentiality and privacy issues. In some cases, practitioners overenthusiastically engage the support of others, which can breach confidentiality. In the ACA Code of Ethics, it states, counsellors do not share confidential information without client consent or without sound legal or ethical justification. Sometimes counsellors believe that they are helping or have sound ethical justification to contact others whom they believe will assist the individual in their recovery. However, this can deter the patient from continuing with their counselling and ultimately halt their recovery. Informed consent is whereby the individual is given all of the information about what the treatment entails and the risks and benefits involved. The necessary conditions for consent are that it's voluntary, informed, and that it's within the sufferer's capacity to provide. The average age of bulimia sufferers is 17, and for anorexia sufferers is 16. As the individuals are considered minors, they are not deemed as capable to provide consent. Therefore, the parents or the legal guardians are informed of the treatment, but often not the individual. This can cause great fear amongst the sufferer as they are unaware of what is happening. In some cases, due to the patient not being informed and educated on the treatment, it is cause for ethical concern as they become scared and anxious about their journey to recovery. Thank you for listening.
Thank you so much, Group 3. I just have 2 questions for you on the Slido. If any of you can answer, but if you're struggling, we can hand it over to Dr. Kavitha. So the first question is, how does cardiomyopathy come about, and is it common in patients with bulimia? Would you like to answer, or do you want to pass it on to Dr. Kavitha?
Well, I don't know specifically how it can come about, but it is known that, especially in patients with bulimia, that cardiomyopathy would be very common, as because they're losing a lot of nutrients and bodily fluids, which are very important in the body system. It can also affect the way the heart works and the heart muscles in turn as well, and that can like weaken them, and it can lead to very like severe complications as well. Yeah.
Do you have anything to add to that, Dr. Kavitha?
Yeah, I agree. Well answered. I think it's because heart is primarily a muscle, and the shape of the heart, the structure of the heart will be impacted by the dynamics of the blood flow, which in turn are related to the nutritional status, electrolyte status. So anything that can alter the electrolyte balance of the blood will change the hemodynamics, which is essentially the dynamics of how blood flows in and out of the heart. And when that changes, then it can cause cardiomyopathy. And there are various types of cardiomyopathies. The ones that are called hypertrophy, where it is bulking the muscle of the heart, which means that they are having thick muscles, which means narrow chambers. Then that can be quite dangerous, or sometimes it can cause dilated cardiomyopathy, which means the chambers are enlarged but the muscle is thin. So those are the various types of cardiomyopathy, but it is essentially like the presenter has answered, the change in the dynamics of the blood flow that causes cardiomyopathy. And sometimes it can be a direct result of some of the medications that they are misusing in order to support their eating disorders. So some of the medications can also cause direct cardiomyopathy.
Okay, so thank you to both of you. And the next question, again, it can go to the speakers. What are the cons of cognitive behavioral therapy?
So, some of the disadvantages of cognitive behavioral therapy to consider for the patient is you have to attend regular CBT sessions, and carrying out any extra work between sessions can take up a lot of the patient's time, and it may not be suitable for people with more complex mental health needs or learning difficulties, as it requires structured sessions. And yeah, that's one of the disadvantages, I guess.
Yeah.
Okay, perfect. So I'm going to hand it over now to Dr. Kavitha for her comments and any other questions that she might have for you.
Yeah, just on that last point about the cons of CBT, which is cognitive behavior therapy, sometimes the people with eating disorders, anorexia or bulimia, may be so physically compromised that they may not have the concentration and the ability to focus on a psychological therapy session. So again, they need to be having that level of nutrition, hydration, to be able to concentrate and sit and listen and process a 40-45 minute session. So sometimes we have to fast track other modalities of treatment like medication, diet, meal plans before they can focus and talk about their thoughts and feelings. So that's the timing of the therapy is also the key. Although they may need it, it is important to understand at what stage they are in terms of accessing the right therapy. More recently, again, you have mentioned about the Maudsley model in managing eating disorders. The newer terminology of using CBT is more around CRT, which is cognitive restructuring or reorientation of thinking. So they are having a deviation from the thinking pattern, so they try and bring it back and restructure it into a framework which can support healthy eating. So that's another. CRT is the newer name for CBT used in eating disorders with specific focus on reorienting the thoughts. So Yeah, that's also important to know. A question to the presenters was just because eating disorder, particularly with anorexia, their thinking is so deviant that even though they may be normal or low body weight, they have the perception that they have got really fat bodies. So, what do you think is differentiating it from a delusion? Because eating disorders, we are not saying they are schizophrenic or psychotic, which is more around having delusions. But in eating disorders, although they are not fat, they believe they are fat. So, how can you differentiate that with a delusion? Any ideas?
I'm not sure because they're not overweight, so I'm not sure how they would see themselves as overweight.
Yeah, no, that's really difficult and tricky, and this is really important in understanding the psychological basis of various disorders, which is more in depth that we do in psychiatry training. So it is in eating disorder, it is called a overvalued idea. It is not a delusion, but it is an overvalued idea. The difference being the degree of comprehension where you can attribute to it. So it may not be significantly abnormal for people to have a sense of themselves as thin or fat. There is an acceptable version of what people may see as fat or thin. Secondly, you may be able to comprehend that idea, but the idea is beyond what you can reason with the person. So it is acceptable, it is comprehensible, and but only thing is it is beyond reason. Although they are not fat, they believe they are fat. So it is called overvalued idea. The delusion, it is entirely false, it's unshakable, and the whole thought process itself, the origin of the thought process, is completely different to what it happens in anorexia. So just to bear in mind that eating disorders are not psychotic disorders. Eating disorder is an overvalued idea, although it is, you could say that it's a false perception, false belief, but they are not delusional. Is that okay? Okay. So in terms of the feedback, really excellent presentation, covered everything under both the headings of anorexia and bulimia, covered the ethical and legal aspects as well. Especially as a child and adolescent psychiatrist, I see lots of young children and young people having early onset eating disorders. You've covered it very well, and the pressure from social media and stuff more recently has increased significantly the numbers. So if we go into the epidemiology, you will know that the number of eating disorder cases are significantly increasing year on year. So this is an area that needs a lot of resources, investment, thinking, but also supporting people in helping them with psychoeducation tools to prevent the condition and the occurrence of that condition. So really well presented, well done to the speakers. Just a piece of advice I would say for future presentations, and this is something I have been told at the beginning of my career as presenting, is to limit the words on your slides. So some of the slides have been really wordy. So you probably can, this is more to do with presenting skills rather than the content. Content is excellent. Everything is really good about the presentation. Just to bear in mind, but future professional presentations, it may be useful to limit the content on your slides to some bullet points, but have some notes, have some cards or something that will assist you to remember what you need to talk about. So just a small piece of advice for future professional presentations, but really well done with the topic.
Thank you.
Thank you so much to Group 3 for presenting. I think that's been a really productive learning experience for everyone, including the comments from the judge. So I think now we can move on to our next one, which is Group 4 presenting on autism. Whenever you guys are ready, feel free to turn your cameras on or whatever you're comfortable with. And whenever you're ready, we're excited to hear your presentation. I think there's 2 people presenting at the moment. It's group 4 presenting on autism first.
Good afternoon. Today we will be giving a presentation on autism. So, what exactly is autism? Firstly, being autistic does not mean that you have an illness or a disease. It just means that your brain works in a different way from other people. Autistic people tend to have a limited social aspect. For example, recognizing other people's feelings or not being aware of social spacing in social situations. ASD is something that you could be born with, or it may appear at a young age. However, if you're autistic your whole life.
Autism can present itself through a variety of symptoms, which are divided into 3 groups. 1. Social receptivity, which is how a person responds to a positive action with another positive action. If a person is lacking in this aspect, they may have a lack of eye contact and facial expressions, not understand others' emotions and thoughts, and may dislike sharing enjoyment, interest, and achievement with other people. 2. Communicative intent, which is the use of facial expressions, gestures, and words to deliver a message. If a person is lacking in this aspect, they may repeat the same phrase, be easily upset by certain tastes, smells, or sounds that they do not like, struggle to initiate and sustain conversations with others, take metaphorical phrases literally, be less talkative than other children, or for young children, they may not participate in make-believe play. The third aspect is they may display restricted and repetitive behaviors, such as a strict daily routine, which they are anxious or upset to make minor changes to, repetitive movements like flapping hands, flicking fingers, and rocking their body. They may be hyper or hyperreactive to sensory stimulations, or they may have narrow or extreme interest in specific topics. Other ways autism can be presented is in extreme anxiety. This can cause sweating, panic attacks, and hyperventilation. This can be triggered by a noisy environment, difficulty in social interactions, in an attempt to be normal by changing their behavior, or by worrying about an uncertain event. Moreover, a person with autism may have over or undersensitivity to light, sound, touch, smells, colors, temperature, or pain. This can cause anxiety and physical pain. It can also be overwhelming, which may cause them to avoid social situations because of these sensory issues. Furthermore, the way in which a person responds to their current situation can be a sign of autism. Firstly, meltdowns, which is when somebody becomes completely overwhelmed by their current situation and temporarily loses behavior control. This loss of control can be verbal, in shouting, screaming, and crying, or physical, in kicking, lashing out, and biting. In contrast, shutdowns can also be a sign of autism. This is a more passive response to being overwhelmed, where a person may switch off or become quiet. These are just some of the more common ways in which autism can be shown in an individual, but this condition can exist in other manners as well. It is more difficult to identify autism in girls than in boys, as girls with autism tend to be quieter and seem to be able to cope better in social situations. Sorry, I think one of our members are having trouble turning on their mic, so I'll just speak for them. So etiological factors, one of them can be a genetic factor. There are many common gene variations which are thought to have subtle effects and may work together to contribute to autism. Rare variants have stronger effects, and these are found in less than 1% of people. Many of the variations associated with autism are rare. Most variations
are inherited from parents and they can be common or rare. Gender and sex. Research shows that ASD is more prevalent in boys than girls, as boys are 4 times more likely to develop autism than girls. Preterm babies. Infants born prematurely are much more likely to be diagnosed with ASD than infants born on time. Researchers found that babies born more than 13 weeks early have a greater risk of developing autism. Environmental factors. Air pollution. Research stated that exposure to air pollution at an early stage of development of the child can lead to autism. In addition, children with a very rare gene called MET, combined with exposure to extremely high levels of air pollution, may have an increased risk of developing this condition. Conditions of the parent or maternal factors can also affect the chance of developing autism. The mother's immune system plays a vital role in the development of autism. If the mother experiences immune system problems, it is very likely that their children will develop this condition. In addition, some mothers have or develop antibodies or proteins which fight infection, which interfere with the child's brain development and could lead to ASD. Moreover, having obesity or diabetes during pregnancy could lead to the child having autism.
Another environmental factor that could affect the chances of the child having autism is metals, pesticides, and other harmful chemicals. According to research, early exposure to heavy metals such as lead and mercury can be very dangerous to the child at early stages. In places such as the Republic of Seychelles, the primary source of food is the consumption of fish and is very common as it is an island. Therefore, people are more exposed to lead through bioaccumulation. In one particular study on twins, scientists used their baby teeth to conduct the research. This was to determine and compare the different levels of metals in a twin with autism and in a twin without autism. Autistic children tend to have a lower level of metals essential to life, such as magnesium and zinc, but have a very high level of lead, which could be exceptionally dangerous. Furthermore, studies also show that altered zinc-copper cycles can be the cause of autism. Moreover, scientists stated that early exposure to particular pesticides at maternity can lead to an increased risk of the child developing the syndrome. Research showed that some contaminants, such as flame retardants, could possibly lead to the development of ASD. Moreover, nutrition is a factor that could alter the possibility of a child developing the disorder. Studies show that taking prenatal vitamins may lower the risk of the child developing autism. Precautions can be taken to reduce the risk of the fetus developing the syndrome by taking vitamins and supplements during pregnancy to protect the child from particular environmental contaminants. Additionally, folic acid intake during early stages of pregnancy can reduce the exposure to harmful chemicals and pesticides to the child, reducing the risk of the child being autistic. Lastly, it is proven that mothers who intake multivitamins have a less likelihood of their child developing ASD.
Sorry, I think there's been a problem with the presentation. I'll start on the next slide. Diagnosing ASD can be difficult because there's no medical test. For example, a blood test can help diagnose iron deficiency to diagnose the disorder. Doctors look at the child's development history and behavior to make a diagnosis. ASD can sometimes be detected at 18 months or younger. Doctors can identify autism by using developmental monitoring, which observes the growth of a child and how they change over time and whether they reach the standard of developmental milestones in playing, learning, speaking and behaving, and moving. If a milestone is missed, the doctor will take a more detailed look through a more in-depth test, which is called developmental screening. This takes a closer look at the development of a child, such as language, movement, thinking, behavior, and emotions, using questionnaires and checklists. This is more formal than developmental monitoring, and therefore is only carried out if the doctor is concerned. If a child is exposed to the etiological factors explained in the previous slide, they are at a higher risk of developmental problems, so healthcare professionals may suggest having additional screenings.
If an area of concern is identified in the screening tool, a comprehensive developmental evaluation will be used. This takes an in-depth view at a child's development, as it is carried out by specialists like a developmental pediatrician, child psychologist, speech-language pathologist, or occupational therapist. This test will establish whether a child requires special treatments or early intervention services. After a person is diagnosed with autism, the doctor will then identify where on the spectrum they are. The spectrum is autism disorder, Asperger's disorder, Rett's disorder, and pervasive development disorder. There are other conditions that present themselves with familiar features to ASD. For example, development delays, which include speech delays, hearing problems, and fine motor issues. There are additional conditions such as anxiety disorder, schizophrenia, selective mutism, and obsessive-compulsive disorder, also known as OCD, and Down syndrome. The development of standardized tests to assess autism, particularly in young children, is a topic of considerable interest in the research community. In recent years, there's been an exponential growth in scales with differential diagnosis. Particular emphasis has been placed on defining and better describing the symptoms of the disorder relative to other forms of the autism spectrum, and identifying the condition at the earliest age they can. We can distinguish between autism and conditions which are similar to it through a series of screenings and tests, which are carried out by a team of experts that specialize in autism, such as a neurologist, psychologist, psychiatrist, and speech therapist.
Treatment options. So, how do we treat the condition? There are many forms of treatments that are believed to be available for autism. Firstly, behavior and communication approaches. This is where skills that help the person live as independently as possible, such as eating, bathing, and relating to people, are developed. In addition, social skills training. This is where skills needed to interact with others, such as conversation and problem-solving skills, are further developed. Lastly, speech therapy. During this, it helps to improve the person's communication skills. This type of therapy can be done one-to-one, where the therapist helps the individual by, for example, using cards. This helps them to understand feelings. So the feelings are put onto a card and they're asked to recognize what the feeling is, and it helps them to put themselves in the situation and understand the environment and how they're supposed to react. Secondly, dietary approaches can be served as an alternative treatment option. So such changes in diet can include removing certain food and replacing it with vitamin and mineral supplements to help improve health and overall protection to the body. The theory is based on the idea that food allergies or lack of vitamins and minerals are the cause of symptoms. This is believed among professionals, but is still being researched into further detail. This might include special diets, dietary supplements, chelation, which is a treatment used to remove heavy metals such as lead from the body, biologicals, for example, secretin, or mind-body medicine. As mentioned, this is still being researched into further detail, but it is an assumption that it helps people with the condition ASD.
Another form of treatment of ASD is medication. Currently, there are no medications to fully cure autism. However, there are some to help people with the condition to function better and reduce the symptoms. Some of the medication used includes to manage high energy levels, inability to focus, anxiety, self-injury, or seizures. Scientists are still working towards creating better medication for people with autism to help them make their daily life activities easier. In addition, complementary and alternative medicine treatments are being performed as treatments. This includes the usage of computer-aided technology. CAM treatments refer to products or services that are used in addition to or instead of traditional medicine.
Prognosis and risks. Some children with autism may improve at the age of 4 to 6, especially if the condition is mild or has been treated at a young age. This can give a huge sense of hope and be an advantage to people who fall under this category. However, to people who are on the severe end of the scale or haven't been treated from a young age due to other reasons, it can come across as a disadvantage. Results have shown that autistic children with IQ above 50 in the UK found that 12% of autistic adults achieved a high level of independence. Some statistics to help support this hypothesis are 10% of autistic adults have a social life, and some are employed, but required some support. This means that their condition is not as severe. 19% of autistic adults had some independence, but were living at home, so they were in need of more support from family. 46% of autistic adults needed specialist residential provision. This means that they need a lot more support and care from more professionals. And 12% of autistic adults needed a high level of hospital care. This means they were more on the severe end of the scale and needed professional help also.
Prognosis also depends on diseases that coexist with autism. These include genetic disorders like Fragile X syndrome, Down syndrome, etc. About 10 to 15% of autism cases have an identifiable chromosomal abnormality, making them easier to find to doctors when observing the baby during pregnancy. Either parent 35 years or older can make the risk of ASD in a child higher. The risk of the child getting the condition goes up with a parent's age. For example, a parent who is 25 has a less risk than a parent who is 40. Furthermore, risk can increase with the situation of the birth of the baby. Babies born early, premature babies, especially at 26 weeks of pregnancy. Also, breech delivery, which means babies are born bottom first, not head, or other birth trauma, and babies born with lower weight than normal, and finally, babies born with birth defects.
Social issues regarding autism. People with autism often find it difficult to recognize and understand other people's feelings or intentions, and this may come off as insensitive. In addition, they are unable to read nonverbal cues and take extra time to process information or answer questions. They repeat what others say, and this is known as echolalia. Moreover, they seek out time when overwhelmed by others and find it difficult to form friendships. Legal issues regarding autism. There are laws that protect people with autism. For example, the Americans with Disabilities Act prohibits discrimination and ensures equal opportunity in employment, state and local government services, public accommodations, commercial facilities, and transportation.
If a person involved in a crime is on the autism spectrum, the way in which the people involved in the justice system communicate with them must be altered accordingly. In addition, it needs to be ensured that the person understands the justice system, the situation they are in, and the court process is essential. Furthermore, an autism expert is needed to help guide the process, and this is helpful to both parties. The diagnosis of an autism spectrum disorder is relevant and needs to be explained to the police and legal personnel. If a person is involved in a crime and is on the autism spectrum, it is essential that others who know the person well to provide information about the person. For example, how they think, how they communicate and interact, and how they understand others.
In terms of the ethical issues regarding autism, there are milder cases of ASD where genetic testing has been questioned for the uncertainty of its scientific validity and its limited clinical utility. In addition, an ASD diagnosis for adults may lead to higher insurance rates, and people may be subject to employment exclusion. Research developments. Research in autism looks at how this condition can be recognized. Since the 1970s, it's been known that genes contribute to the chance of autism. Recently, there's been an investigation into gene variants that could play a part in the development of ASD. A recent study analysed the DNA of over 35,500 people from all over the world, 12,000 of which have autism. In this investigation, scientists established variants of 102 genes that were linked with an increase in the chance of developing autism. Moreover, scientists have looked at neurological factors to explore the links between certain types
of cell malfunctions and ASD. They also have linked at how ASD can be linked imbalances in the gut biome.
These are all the links that we use to help conduct our research for the presentation.
Thank you for your great presentation. Now, before I pass it on to Dr. Kavita for her comments, there is one question on the Slido that I'd like to pass on to you guys. So the question is, what is the difference between psychiatrists and psychologists?
So psychiatrists, well, one is psychiatrists have a medical degree, so they can prescribe medicine and they are able to give medication to people who need it, whereas psychologists are more therapy-based, so they can give CBT treatments and they can help with more one-to-one communication and help through mentally and how, like, find the base of the problem rather than prescribe like antidepressants and stuff like that.
That's great. Thank you. Now I'd like to pass it on to Dr. Kavita for any questions and comments. Thank you.
Yeah, thank you. Thank you to the presenters and thanks, Aryan. Again, very well researched topic, excellent presentation, impressive slides, and well presented, although there were some technical glitches. I think we were having problems with the screen share, but it didn't interrupt the flow. Very well delivered. A question I was thinking whether you found anything that was interesting in terms of causative factors for autism that created a myth in the 1990s that had to be extensively evaluated over and over again to demystify some of those myths which still exist to the current day. Do you know what it might be, or have you read anything about a myth that developed in late 1990s about cause of autism? Okay, no worries. I'll just mention it because in late 1990s, there was a researcher called Andrew Wakefield who invested in extensively trying to understand whether MMR vaccine was causing autism. So one of the things that came up from his research study was a direct link between MMR vaccine and autism, which then caused a whole lot of, obviously, in the public domain, there was a lot of noise that vaccines should be abandoned and serious implications around how to control infectious diseases that were being controlled by vaccines. So eventually it turned out the way the research works is rubbish in, rubbish out. So if you put data in that was dubious or not fully critically evaluated, then the outcome of your research would be also dubious. So for people to be really convinced about the outcome, you have to really be critical on appraising any evidence. So even today, I, as a child and adolescent psychiatrist, I'm involved in lots of diagnosis, evaluations on autism. So that's the bread and butter of my job. But we still do get some parents and families who question whether it was caused because of MMR vaccine that was given to their child during their early years. So yeah, so that's just an interesting fact about autism and vaccines. And we have confirmation by a number of studies that followed through to say that vaccines do not cause autism. Well done, all presenters, and really good presentation.
Thank you to Dr. Kavita. Sorry. So now we have group 5 who will be presenting about bipolar disorder. Also, cameras are encouraged to be on, please. So good luck in taking it away.
Sorry, Kaya's not in at the moment, so we're waiting for her.
Yeah, no worries. Take your time.
Thank you. Guys, are we ready?
Yeah, I'm ready.
Kaya?
Sorry, yep, I'm ready now.
Good afternoon, everyone. My name is Ella.
I'm Kaya.
And I'm Diana.
Today we will be talking about bipolar disorder. What is bipolar disorder? Bipolar disorder is a mental health condition that affects your mood. People with bipolar disorder often have episodes of depression, which makes you feel low and lethargic, or you could experience mania, which makes you feel very high and overactive. Types. There are 4 types of bipolar disorder. The first type is bipolar 1 disorder. This means you've had at least one manic episode that may be followed by hypomanic or major depressive episodes. In some cases, mania may trigger a break from reality. The second type is bipolar 2 disorder. This means you've had at least one major depressive episode and at least one hypomanic episode, but you've never had a manic episode. The third type is cyclothymic disorder. You've had at least 2 years or 1 year of many periods of hypomania symptoms and periods of depressive symptoms. And the last type is bipolar-related disorders induced by certain drugs, alcohol, or due to a medical condition, such as Cushing's disease, which is when you gain weight and bruise easily, or stroke.
The symptoms of bipolar disorder. So symptoms of bipolar disorder depend on which mood you're experiencing. Unlike mood swings, each extreme episode of bipolar disorder can last for several weeks. Bipolar disorder is characterized by extreme mood swings. These can range from extreme highs to extreme lows. There are 2 phases, depression and mania. Some symptoms of depression include feeling sad, hopeless, or irritable most of the time, lacking energy, difficulty concentrating and remembering things, loss of interest in everyday activities, feeling empty or worthless, feeling guilty, feeling pessimistic about everything, self-doubt, being delusional, having hallucinations, lack of appetite, difficulty sleeping and waking up early, and finally, suicidal thoughts. So the extreme nature of the condition means staying in a job may be difficult and relationships become very strained too. So in combination, all these aspects and the drastic mood swings can cause an unfortunate increased risk of suicide. Mania and hypomania are 2 distinct types of episodes, but they have the same symptoms. Mania is more severe than hypomania and causes more noticeable problems, which could cause problems in people's personal lives. Mania may also trigger a break from reality and will require hospitalization. The manic phase of bipolar includes symptoms on the opposite side of the spectrum, for example, feeling very happy, elated, or overjoyed, talking very quickly, feeling full of energy, feeling self-important, feeling full of great, new ideas, having important plans, being easily distracted, being easily irritated or agitated, being delusional, having hallucinations and disturbed or illogical thinking, not feeling like sleeping, not eating. And a very common symptom is doing things that often have disastrous consequences, such as spending large sums of money on expensive and sometimes unaffordable items, and making decisions or saying things that are out of character and that others see as being risky or harmful.
Consequently, the extreme mood swings have a detrimental effect on the person's life in all ways, including jobs, relationship, and friends, etc., with other examples. Symptoms of bipolar disorder can be difficult to identify in children and teens. It's often hard to tell whether these are normal ups and downs or it's a result of stress or trauma. Children and teens may have distinct major depressive or manic or hypermanic episodes, but the pattern can vary from that of adults with bipolar disorder, and moods can rapidly shift during episodes. Some children may have periods without mood symptoms between episodes. The most prominent sign of bipolar disease in children and teenagers may include severe mood swings that are different from their usual mood swings. Etiological factors of bipolar disease. So there are biological differences. So people with bipolar disease appear to have a physical change in their brains. The significance of these changes is still uncertain, but may eventually help pinpoint causes. Then there's the genetic side. So bipolar disorder is more common in people who have a first-degree relative, such as a sibling or a parent with the condition. Researchers are trying to find genes that may be involved in causing bipolar disorder. It's actually known to be the most heritable genetic disorder. There are also trigger causes. For example, having a first-degree relative, such as a parent or a sibling with bipolar disorder, periods of high stress, such as the death of a loved one or a traumatic event, and finally, and most commonly, drug or alcohol abuse. Research also shows that bipolar disease affects men and women equally, but women are 3 times more likely to experience rapid cycling of mood episodes. They are also more likely to experience depressive and mixed episodes of the disorder compared to men.
Pathophysiology. The clinical symptoms of bipolar disorder do not appear to be correlated to the changes in the function or structure of specific brain areas. Rather, bipolar symptoms manifesting as emotional, cognitive, behavioral, autonomic, immune, and circadian disturbances better correspond to the dysfunction of interconnected brainworks. One perspective emphasizes a critical role of 2 interrelated prefrontal limbic networks in the physiology of bipolar illness. The first of these networks, commonly referred to as the automatic internal emotional regulatory network, consists of a loop which includes the ventromedial prefrontal cortex, PFC, the subgenual anterior cingulate cortex and thalamus. This modulates amygdala responses to endogenously generated feeling states, such as melancholic feelings induced by memories of past losses. The second of these networks is commonly referred to as the external regulatory network. The dorsolateral prefrontal cortex, with its connections to the ventrolateral PFC, is commonly described as the origination point of cognitive regulatory. The ventrolateral PFC network modulates externally induced emotional states and assists with cognitive emotional regulation and suppresses the manipulative effect. These 2 networks have shared components and collaboratively regulate amygdala responses in complex emotional circumstances components of this complex. Living with bipolar. The high and low episodes of bipolar disorder are often so extreme that they interfere with everyday life, but there are several ways to treat bipolar disorder that can make an impact. They aim to control the effects of an episode and help someone with bipolar disorder live life as normally as possible. The following treatment options are available. Medication, which prevents episodes of mania and depression. These are known as mood stabilizers, and you can take them every day on a long-term basis. You can also take medicine to treat the main symptoms of depression and mania when they happen. The second is psychological treatment, such as taking therapy, which can help you deal with depression and provides advice about how you could improve your relationships. Therapists can also give you lifestyle advice, for example, doing regular exercise, planning activities you enjoy that give you a sense of achievement, as well as advice on improving your diet and getting more sleep. It is thought using a combination of different treatment methods is the best way to control bipolar disorder.
The diagnosis. As we mentioned above, there are 4 types of bipolar disorders. Type 1 is characterized by at least one episode of full-blown mania or mixed episode, manic and depressive symptoms, as well as at least one depressive episode usually. The diagnosis of type 2 specifies several protracted depressive episodes and at least one hypomanic episode with the absence of manic episodes. For a cyclothymic disorder, it is several periods of hypomanic and depressive symptoms along with depressive symptoms which do not meet criteria for the depressive episodes. Lastly, we have bipolar disorder not otherwise specified. In this case, the patient might show depressive and hypomanic-like symptoms and episodes that might alternate rapidly, but do not meet the full diagnostic criteria for any of the disorders on the left. Now, the criteria above contain some limitations, which I am going to discuss in the next slide. Bipolar disorder type 1 and 2 are especially difficult to diagnose accurately in the clinical practice, particularly in their early stages. Only 20% of the patients with bipolar disorder who are experiencing a depressive episode are diagnosed with the disorder within the first year of seeking treatment, and the mean delay between illnesses and onset diagnosis is 5 to 10 years. Challenge of differentiating bipolar disorder type 1 or 2 from unipolar depression, an illness characterized by characterized by recurrent depressive episodes, especially in patients who present during a depressive episode and in those with no clear history of mania or hypomania. The misdiagnosis to unipolar depression is the most common in type 2, since for this type, the patient never experienced mania episodes. Apart from that, the nature of this disorder is that patients with type 1 and 2 experience more depression episodes than maniac or hypomanic ones. And this disorder often starts with the depressive episode. This impacts massively on the diagnosis. The evidence supporting this is that the 11-year rate of conversion to bipolar disorder type 2 is 9%. Subthreshold symptoms of hypomania are common in unipolar depression as well. These symptoms might be more common than was previously thought. They are present in 30 to 55% of the people during a depressive episode and are common in unipolar depression. At least a subset of patients with treatment-resistant unipolar depression might have been misdiagnosed bipolar disorder. Misdiagnosis of bipolar disorder type 1 or 2 as unipolar depression has many potentially deleterious consequences, including prescription of inappropriate drugs, such as antidepressants in the absence of mood-stabilizing drugs, which might lead to switching to mania. Therefore, we need criteria that specifies these subtypes as well as differentiating with unipolar depression in the early stage of this disorder. The current treatment of bipolar disorder focuses on acute stabilization, in which the goal is to bring a patient with mania or depression to a symptomatic recovery with stable mood and to maintain it. Therefore, the doctor should aim to prevent the relapse, reduce subthreshold symptoms, and enhance social and occupational functioning. The treatments are either medical or psychological. Let's start with the medication. Lithium is the most commonly used mood stabilizer. Lithium has multiple pharmacological effect on multiple signaling pathways and other cellular processes. The effects of lithium are not easy to categorize in a simple linear hierarchical manner, but generally it helps reduce the severity and frequency of mania. Valproate is an inhibitor of succinic semialdehyde dehydrogenase. This results in an increase in succinic semialdehyde that will inhibit GABA transaminase, ultimately reducing the breakdown of GABA and increasing GABA-generic neurotransmission. As GABA is an inhibitory neurotransmitter, when binding to GABA-A receptors, it will trigger inhibitory postsynaptic potential, preventing the action potential and resulting in the depression in the central nervous system. Valproic sodium is converted to valproic acid in the gut. Therefore, the mechanism is mostly the same as above. Carbamazepine. The full mechanism of this drug still remains unclear. However, I think two of the possible ones are closely related to the disorder. The first one is the upregulation of GABA-B receptors, and the other is the decrease in dopamine turnover. Carbamazepines are associated with the upregulation of GABA-B receptors in the hippocampus, yielding this action as a potential convergent mechanism for mood stabilization. This drug is a GA-GABA receptor agonist, as it has also been shown to potentiate GABA-A receptors. This could possibly lead to depression in the CNS. Carbamazepine also exerts its action on the dopamine system through some other series of mechanisms. Chronic administration of this drug reduced D2, which is dopamine D2 receptor density. Dopamine levels have been reported to increase in the prefrontal cortex via chronic carbamazepine administration. The atypical antipsychotics, the AAP, also known as the second generation antipsychotics, and serotonin dopamine antagonists, produce fewer extrapyramidal symptoms, but weight gain is more common with olanzapine because they selectively bind to D2 receptors as well as serotonin receptors. Therefore, this would lead to a rise in dopamine level in specific area of the brain, and thus reducing the extrapyramidal symptoms. Also, combined olanzapine and fluoxetine leads to more symptomatic improvement than does olanzapine or placebo alone, which could suggest that fluoxetine is an effective treatment of acute bipolar depression, or that a combination of fluoxetine and olanzapine is synergistic. Some worrisome adverse effects of the drug include weight gain, change in lipid levels, and abnormalities in glucose tolerance. Thus, a patient who had a good response to a classic neurolipid in the past should probably be treated with the same drug when a recurrent maniac episode occurs. Antidepressant drugs may include a switch from depression to mania. Whether or not to give the drug depends on if the mania events include self-harm and harm to the family. Psychological therapies are often combined with the medication in the long-term treatment, as they are proven to be more effective than medication or therapies alone. Goals of adjunctive psychotherapy for bipolar disorder include the education of patients and, when possible, caregivers about strategies for the management of stress, the identification and intervention of early signs of reoccurrence, and how to keep regulate lifestyles, for example, sleep and exercise habits. Moreover, and in view of the high rate of non-adherence to drug treatment, and psychosocial treatment emphasize consistency with pharmacotherapy. There are few common types of therapies. Family-focused therapy. The treatment consists of conjoinment sessions of psychoeducation regarding bipolar illnesses, communication enhancement training, and problem-solving skills training, combining with medication. The interpersonal and social rhythms therapy uses a problem-solving approach to interpersonal problems by encouraging patients to maintain and regulate daily routines as well as sleep and wake-up rhythms.
Analytics. Here are some of the statistical facts about bipolar disorder. About 1% of the world's population are suffering from bipolar illness or type 1 bipolar disorder. There is a considerable evidence that people with bipolar disorder are more creative when effectively treated than when they are not treated. About 50% of patients with bipolar illness have family history of the disorder. Studies of twins suggest that the concordance for bipolar illness is between 40% and 80% in monozygotic twins and lower 10 to 20% in dizygotic twins. This suggests a role of genes in the role of genesis in the disorder. On the basis of family studies, the risk of bipolar disorder in the child or sibling of a person with the disease is about 10%. In the 1980s, it was estimated that as much as half the sales of carbamazepine were for bipolar illness. Relatives of bipolar 1 and bipolar 2 probands have elevated risk of unipolar disorder as well as 14% and 17.3% respectively compared to relatives of controls, which is 5.8%. The risk of affective illness, including bipolar, unipolar, and schizoaffective disorder, among offspring and found a significantly higher risk if two parents have affective illness, around 74%, than if only one parent is affected, which is 27%. Now, the ethical factors. So there are 4 pillars of medical ethics: autonomy, beneficence, non-maleficence, and justice. In medical practice, the definition of autonomy is usually expressed as the right of a competent adult to make an informed decision about their own medical care. Bipolar disorders impact the ability to make judgments and to take decisions during mood episodes and remain a stigmatized condition. Early interventions, even those in the prodromal phase, pose ethical questions for both clinicians and researchers. The degree of patients' autonomy in their clinical care must also now be considered from a biomedical ethics perspective. One apparent issue could be that the patient with bipolar disorder gives consent to a certain operation during their episode, and then they do not remember this later, or they reject a very important treatment that can be life-saving. Here are references, and thank you for listening.
Thank you.
Okay, thank you so much to Group 5 for presenting on bipolar disorder, and I'm going to one last time hand it over to the judge for, actually, one second, before that, I'm going to ask from the Slido, there are 2 questions. So the first question says, any of the speakers can answer this, says, you mentioned the use of anti-epileptic drugs. In this case, does bipolar disorder also have seizure fits?
I am not sure about this question, and I haven't come up with this during the research. I'm sorry.
No problem. Maybe Dr. Kavita can answer it.
Yeah, the medications that are used in bipolar disorder are anti-epileptic medication. The purpose of using anti-epileptic medication in bipolar is to stabilize the mood. The reason they work is by stabilizing some of the chemicals in the brain that are responsible for mood fluctuations. The chemicals that cause epilepsy are also very similar, although the reason for using it in epilepsy is different. So there it is to control the fits, where there is abnormal electrical activity in the brain that is triggering electrical signals to be fired from the brain to the other parts of the body, which means that uncontrollable involuntary movements are happening in parts of the body. So that's the reason they are used in fits, which is epilepsy and seizures. So that's why they are called anti-epileptic medications, because they have been designed to control epilepsy. There is no correlation between bipolar disorder and epilepsy as such. So, however, the medications, they have got overlap in terms of how they can help both seizures as well as mood fluctuations.
Okay, thank